A new academic year begins for Korean students come March, and relevant officials are seeking to ensure a safe learning environment as well as an effective treatment strategy for those infected. For more on these efforts, I have Professor Kim Moon-kyu from Yonsei University. Professor Kim, welcome back.
Thank you for having me.
Meanwhile, I have Dr. Alice Hyung-Tan at Ms. Medi Women's Hospital live on the line. Dr. Dan, it's good to see you again.
Good afternoon.
And also joining this session virtually is Professor Peter Chin Hong at the University of California, San Francisco. Professor Chin Hong, it's a pleasure to speak with you again.
Always a joy, Sunny. Thank you.
Right, Professor Kim, we'll start here. Let's begin with the risks faced by children here in Korea in light of Omicron.
If you ask me whether children are more susceptible or not, my answer is yes and no. You know, at the beginning of the pandemic, this coronavirus was not that a big problem with children. So they started with a low incidence in children, but now, as the adults are all vaccinated, the main population getting infection is moving to the younger generation. So if we compare with adults, children are relatively susceptible right now. So it's in a confusion. So it is too early to draw a final conclusion. But one more thing I would like to mention is, as we see many patients in the hospital, they come and they do not come because of Omicron. They come with other reasons, and they are accidentally found to have positive results of coronavirus, which must be Omicron. So that means the increased instance of hospitalization in children might happen like this way. So we have to see and look whether they have severity or not. If it's not, we don't have to worry about the situation until now.
Right, I see. Dr. Tan, some believe children and teenagers will account for about 30,000 daily infections starting late this month. Do you share this outlook?
Yes, that's certainly possible. If we look at the overall incidence of COVID-19 in the children and adolescent population, that actually accounts for the largest incidence rate compared to all other population groups in our country. The cumulative incidence overall of COVID in our population is 2,800 per 100,000 people. Whereas for children and adolescents, the incidence rate is now about 4,000 per 100,000 population, so about 40% higher in children and adolescents. Over the last 4 weeks, there has been a significant increase in the absolute number of cases in children aged 18 and younger per week. If we compare the third week of January, there were about 9,500 cases over that 1 week period, pediatric adolescent cases. During the second week of February, that number per week had increased to 76,870 per week, a huge increase, an 8-fold increase in new pediatric cases over a 4-week period. And so now that children will be back in school starting March 2nd, I think that we can anticipate an even higher number of pediatric COVID cases.
Right. Meanwhile, over in the US, Professor Chin Hong, a study by the CDC published on Tuesday, I believe, showed COVID-19 hospitalizations among children rose in the presence of Omicron, especially for those aged below 5. Do tell us more about this.
Yeah, so like Professor Kim was saying, it really reflects who is not vaccinated. And again, many kids were coming into the hospital for many other reasons. Kids come into the hospital during winter time, and because we do universal screening at the time they come into the hospital, they were diagnosed with COVID, didn't necessarily come in for COVID. Of course, kids come in for other reasons as well with COVID, and we found out in the pediatric population, and a lot of them get a lot of inflammation in the large airways. So it sounds like croup or something in the pediatric population. But nevertheless, 4 times more kids hospitalized in Omicron versus Delta. Not all of them really had COVID, were ill with COVID. And is probably a reflection of high rates of obesity and other comorbid conditions in the American pediatric population, say compared to the UK.
Right, I see. Now, here in Korea, though, Professor Kim, authorities have yet to note an alarming surge in the number of COVID-19 hospitalizations among children, and most of them are being treated at home. Having said that, what can you tell us about their treatment regimen at home?
Well, it's something not easy, not we are accustomed. I mean, even the doctors and even the patients, they're going to phone call the cases twice a day, and this kind of medical service is quite new, maybe the first time in Korea for pediatric age group. I don't know whether we have enough manpower, experienced manpower to cover all the needs, and the other phone is going to work properly day and night without any delay or something. Because as I work in the emergency department, I got a lot of phone calls, and it's really frustrating for them and also for me. And we have to understand that there are more limitations in pediatric age group. So if I say pediatrics is one of the most difficult area for developing telemedicine, so definitely we're going to need some revisions of this policy in the near future.
Right. And for the sake of comparison, Professor Chin Hong, do tell us a bit about the standard treatment procedure for pediatric COVID-19 patients over in the U.S.
So I think it's supportive care as much as possible. And part of the reason is that many of the clinical trials that we take for granted, remdesivir, steroids, etc., they were all mainly done in adults. So we have to extrapolate the results to children. So it's really done on a case-by-case basis for the most sick pediatric patients. For example, remdesivir, really FDA approved for above the age of 12, but under the age of 12, it's used on a case-by-case basis. The same as with some of the other anti-inflammatories and steroids. And of course, in the outpatient setting, molnupiravir is not indicated for kids under the age of 18 because of the effects on fertility and on young growing bones. And of course, Paxlovid is only above the age of 12. So we're very limited when we come to both data as well as potential agents for treating kids.
Right. Dr. Dan, authorities on the local front, meanwhile, have secured 135 hospital beds in the Greater Seoul area for pediatric COVID-19 patients. And like Professor Kim mentioned, there are efforts to include children's clinics in the country's telemedicine campaign. What are the implications of these efforts?
Well, first of all, telemedicine, as was mentioned, is very new in Korea, and it is a bit of a controversial issue. If we remember back in August 2020, there was actually a nationwide strike among doctors in training after we tried to implement telemedicine. And I remember during the MERS outbreak in 2015, I tried to implement telemedicine in our hospital, and I was actually met with a lot of resistance initially. However, it was a way that we could contact and stay in touch with our patients during our 1-month hospital shutdown during MERS. And that's what telemedicine is all about. It's about access. Patients could have difficult time accessing hospitals during COVID, and doctors can access their patients who are in need of medical guidance during acute COVID. In the case of Omicron, it's also about safeguarding hospitals and safeguarding healthcare workers against infection with COVID. So I think expanding telemedicine is the right direction to move in. In terms of securing additional hospital beds for pediatric patients, it is true that most children with COVID-19, they will recover. However, we need to be mindful that there are still vulnerable populations within the pediatric group, children with diabetes, children with immunocompromised states. And so we need to prepare hospital surge capacity to take care of these children. And then also, of course, there will be children who are diagnosed incidentally with COVID-19, as Professor Kim mentioned. And so we need to have isolation beds ready and prepared for these children who come in with other acute conditions, but who are incidentally found to have COVID-19.
And speaking about being mindful, Professor Kim, what COVID-19 symptoms do parents need to be aware of while taking care of their children at home?
Well, it's happening from a small baby less than 1 month to a teenager. And if I start from the infants, usually they just have fever. And if it's combined with poor oral intake, baby can easily be dehydrated. So caregivers have to check the diapers and see whether the urine output is decreasing or not. If it's decreasing, it's worrisome. And toddlers may have more variety of symptoms like coughing, fever, irritability, vomiting, diarrhea. Again, dehydration is the main problem we have to prevent. And let them drink more water than usual. And food should be something easily digestible. And children who can express their will, they have more easy to understand their situation. So as you might have noticed, this COVID-19 symptom, maybe the Omicron, is just like a common flu or intestinal flu. So hydration is very important, and the children might have to use a separate room in home, inside the house. And family members should keep about 1 meter distance from the patient, and we might have to limit their movement inside and open the windows for frequent ventilation, and some say even sunlights are good for health to recover. But there is a high risk, as Dan mentioned, in children, severe obesity seems to be a high risk, and kids with diabetes, congenital heart disease, with epilepsy, chronic lung disease. And one more thing from the recent report from Journal Pediatrics, feeding tube dependency is another risk factor. So if the patient belongs to this criteria, I strongly recommend to have vaccination. And the third issue is about the caregivers. Somebody's going to care for the baby at home, right? So we have to designate one person who's going to be responsible until the recovery, and you should not change the person. The caregiver should wear a mask, wash hands every time the person has a contact with the children, and the patient should not share cup or towel or some dishes like that. If possible, we have to control the waste products, and I think no visitors should be allowed. And the caregivers have to know the phone numbers of the clinics they can contact with.
Right, and moving from treatment back to vaccination, Professor Chin Hong, on the vaccination front, what has been disclosed about Pfizer's ongoing clinical trials with regard to its vaccines for toddlers from 6 months to children aged 4?
Yeah, so I'll give you a little bit of history, Sunny. So first, a few weeks ago, we got the results of the trials, and it showed that between 6 months and 2 years, the dose of 3 micrograms seemed to do quite well with a 2-dose regimen. But in the 2 years to 5 years, it didn't do quite as well with 2 doses. So they said, let's go back to the drawing board, let's give a 3rd shot and look at that efficacy. But meanwhile, Omicron was raging, and there was a lot of thought that maybe we can start the vaccine series with 2 shots in the under 5 and maybe wait for the data for the 3 shots, assuming that it will work. Turns out that that was controversial, and then last Friday, the FDA said, wait a minute, we'll wait 2 months for the full 3-dose series before, approving it or, having this reviewed by the Scientific Advisory Board. And at the same time, Omicron is going down very dramatically, so there was less pressure to do it. And I think a lot of people agreed with that because, again, you want to have the best foot forward to increase trust in the people who would then bring their kids to get the vaccine.
Right, of course. Dr. Dan, some 20 countries, including the US, have granted the green light for COVID-19 vaccinations for children aged 5 to 11. Do you suppose Korea should do the same, that is, especially as Professor Kim mentioned, those with pre-existing health conditions?
Yes, and we should be mindful that COVID-19 will be an endemic disease. We cannot predict the future virulence of COVID-19. We hope that it will become milder, but there is no guarantee. In the near term, COVID-19 will remain a potentially fatal disease among children. And the best way to protect our children against this infectious disease, just as we protect them against influenza, chickenpox, and the measles, is through vaccination. We should also keep in mind that long COVID is a up and coming, it's an emerging public health crisis. Researchers have found that having had COVID-19 is now a major risk factor for cardiovascular disease. And so I think we need to protect our children against having a risk factor for heart disease and stroke and blood clots, which is what long COVID could be in children. There are so many unanswered questions. Now, I do have a sense of conflict, I would say, because I do know that there are many people around the world, including healthcare workers, who have not even received one dose of a COVID-19 vaccine. And so I think that just means we need to work harder. We need to work harder to make sure we have global equity. But vaccinating our children, I don't think should be an either or issue. I think we need to protect them against COVID-19. And the recently published phase 2-3 clinical trials that showed that 2 doses of 10 micrograms of the Pfizer vaccine spaced 21 days apart, that this is safe and efficacious immunogenetic in children between 5 and 11 years. And so I support vaccination in this age group.
Right. And staying with vaccination, Professor Kim, the rate of COVID-19 inoculation among teenagers here in the country, that would be those aged 13 to 18, stands at 81%. Having said that, what would you like to share with those who have yet to receive their vaccines?
Well, yeah, as everybody now, I think, understand children with high-risk health conditions should have vaccinated. And I recommend we can provide more safe and more effective one. And actually, I'm waiting for a clinical study in children age group with Novavax, and as that make me remember of the basic vaccine schedules we already had before this pandemic, and children should not miss their basic vaccination schedule. We should continue with that, and I hope that we can add on a safe and effective corona vaccine also.
Right, hopefully. Dr. Tan, as my colleague Soa mentioned earlier, school children and faculty members are being recommended to take rapid antigen tests twice a week come March as part of COVID-19 prevention efforts within the academic arena. Having said that, what are your thoughts on the practicality of this particular measure?
I think it's completely practical. I mean, this is a strategy that's been in use in schools and universities in the United States for over a year, and it's been successful. Doctors at Stanford, Harvard, the University of Maryland, Brown University, Johns Hopkins University, they recently published a report looking at different testing strategies to help facilitate in-person learning for students. And what they found was a weekly universal testing protocol prevented approximately 50% of in-school transmission. And they also stated that this type of universal testing would lower projected societal costs compared to hybrid or remote schooling. Also, they found that the cost per infection averted declined as community transmission increases. And that's exactly what's going on in our country right now. So I think test to stay protocols and also universal screening, weekly screening protocols are effective. They're practical, they work. And we talk a lot about the layered approach to fighting this pandemic. This type of testing protocol is one more tool that we can use to help keep our children safe and to keep schools open.
Meanwhile, Professor Chin Hong, over in the US, given the dramatic decline in Omicron cases in recent days, I understand authorities there are looking to ease restrictions, including the mask mandate within school grounds. What are your thoughts on this?
Well, I think it's understandable that people are feeling frustrated. I think in California, which has one of the biggest school systems in the country, we're being a little bit more cautious. So the school mandates are still going to be in place and are going to be readdressed in the next 2 weeks. And as been said, you know, I think wearing a mask is such an easy thing. It's acceptable by kids. And because California had closed their schools for in-person instruction for so long, there's a lot of pressure to keep these schools open as much as possible. In other states that have opened and closed, there's probably a little less pressure. So now only 7 states and the District of Columbia still have school mandates for kids. So the best advice, build a wall of immunity, vaccinate all of the people around those kids to make it as safe as possible for the children who are still going to school, and we want them to stay in those seats.
Right, we do. And Professor Kim, very briefly speaking, let's end today's session with a few words of advice for children with regard to efforts aimed at tackling Omicron.
Well, I would like to ask for the government, not for the children. You know, as I was on duty this morning, it's very difficult. You know, emergency departments are frequently closed because we have confirmed cases and we have to disinfect all the areas. So as the Korean Pediatric Society recommended, I mean, we need more manpower to prepare for a high rise. I think we might face more higher cases in the following weeks. So I wish that we can have some drastic measures. We can help these confirmed cases dealing with those health issues.
Right, proactive efforts to bolster our workforce then.
Yeah.
Professor Kim, as always, thank you very much for your
Thank
thoughts.
you.
Dr. Dan, thank you for being with us today. And Professor Chin Hong, always in the US, thank you for your insights.